Dr. Mihir Prakash Pandia is a professor and a professor from AIMS New Delhi, and is a executive member of ISNAC. He has got 59 publications to his credits. So he will be elaborating on the neuroprotection in perioperative neuroanesthesia and also in the neurocritical care. We welcome you, sir. Over to you, sir.
Very good morning, respected chairpersons, ladies and gentlemen. Killing the demon Mahishasura was no easy task. So goddess Durga had to take multiple weapons from different deities, like Sudarshana Chakra from Vishnu, Trishula from Shiva, Vajra from Indra, and so on. Cerebral ischemia, the final pathophysiological mechanism for all acute neurological injuries, is not less than a demon, and we need multiple approaches or multiple weapons to deal with it. There is a short verse in Upanishad, Jat Pinde Tat Brahmande, that means everything is alike, or in the words of the learned Leonardo da Vinci, everything relates to the other. Generally, we tend to ignore little things in our lives, little things in every aspect of life: health, happiness, interpersonal relation, wealth creation, every aspect of life, where these little things with their cumulative or compounding effect make huge difference to our lives. And neuroanesthesia, anesthesia, critical care or cerebral protection is not different. So in next 15 minutes or so, I'll be talking about those little things in our armory of anesthesia and critical care that we can use to deal with the demonic cerebral ischemia. Acute brain injury, whatever its cause, is associated with significant morbidity and mortality, and the end point of all acute neurological injury, whether ischemic, traumatic or any other type, is cerebral ischemia. And ischemia triggers a characteristic pathological cascade that leads to neuronal cell loss. The outcome after acute neurological insult depends on the primary injury and secondary injury. Primary injury is caused directly by the trauma or ischemia, leading to immediate cell loss, and the secondary injury is a continuum of the primary injury with the delayed presentation. So cerebral ischemia has been divided into global cerebral ischemia, which results from global decrease in the cerebral perfusion because of cardiac or non-cardiac causes, and focal cerebral ischemia occurs because of small vessel occlusion, cerebral embolism, vasospasm, and direct injury to the vascular structures. So whenever there is a focal cerebral ischemia, there is a dense ischemic zone called core, which is surrounded by a partly variable or partly ischemic zone that is called ischemic penumbra, and this zone is compromised but still viable. And this zone, the ischemic penumbra, is very important from the cerebral protection point of view, because if we can restore circulation or track measures that can prevent extensive secondary injury, then we can improve the neurological outcome. This is just a brief way of describing the cascade of cerebral ischemia. So whenever there is cerebral ischemia, there is anaerobic glycolysis, and that leads to accumulation of lactic acid. And with that, there is increased cell permeability, increased cerebral edema, leading to increased intracranial pressure. And whenever there is intracranial pressure high, that leads to compromise of the cerebral circulation, and that aggravates further ischemia. So with ischemia, there is depletion of ATP and the energy dependent ion pumps that leads to membrane depolarization and accumulation of sodium and potassium inside the cell, and release of different excitatory neurotransmitters, and that starts a self-digesting process leading to neuronal cell death. So the practice of preventing or minimizing the effect of extensive secondary injury that occurs following ischemic, traumatic or any other type of acute neurological insult is called cerebral protection, which we need in different situations, like during the intraoperative period, ischemic stroke, subarachnoid hemorrhage, head trauma, tumor or edema, or status epilepticus, or many general medical conditions like sepsis, hypoxic encephalopathy, hepatic encephalopathy, and post-cardiac arrest situations. And there are multiple approaches for providing cerebral protection, like avoiding mechanical trauma during surgery, reducing the duration and intensity of ischemia, restoration of blood flow, augmentation of blood flow, reducing the metabolic activity of the cells, and providing cytoprotective and neuro repair strategies. So refined surgical technique is very, very important during the intraoperative period. Of course, that is part of the surgeon, but as anesthesiologist, we can do a lot by providing a relaxed brain with the help of steroid, head of position, mannitol, hyperventilation, and CSF drainage, and with that we can reduce retractor-induced ischemia, which is one of the important cause of trauma during the intraoperative period. Of course, we can use different monitoring techniques like MEP, SSCP, and BAEP, and that can guide the surgeon for preventing trauma to important neural structures and neural tracts. Avoidance of risk factor for secondary injury, like avoidance of hypotension, hypoxia, hypercarbia, hyperthermia, hyperglycemia, and anemia, is one of the most important strategy of cerebral protection. And in this regard, early removal of hematoma, control of intracranial hypertension, and control of seizure are also important. So cerebral perfusion pressure, we know it is mean arterial pressure minus intracranial pressure, and this is the one of the most important determinant of cerebral blood flow. So whenever there is decrease in the cerebral perfusion pressure or mean arterial pressure, there is chance of aggravation of cerebral ischemia. So hypertension should be avoided at any cost. Intracranial hypertension decreases the cerebral blood flow by decreasing the cerebral perfusion pressure. A lot of studies have shown that with intracranial hypertension, the morbidity and mortality increases in any acute neurological condition. So control of intracranial hypertension is also very important. So whenever there is intracranial hypertension, that should initially be treated with head-up therapy, adequate ventilation, sedation, CSF drainage, and if that doesn't work, then we go to the tier 2 therapy in the form of osmotic diuretics and hyperventilation, and finally if that doesn't work, then we go to the tier 3 therapy in the form of therapeutic hypothermia, barbiturates, and decompressive craniectomy for the resistant intracranial hypertension. Hyperglycemia adversely affect the outcome after ischemic studies. A lot of studies have shown that, and it is generally recommended that the blood sugar should be kept between 140 to 180. Similarly, anemia, another risk factor for aggravation of secondary injury, and it is recommended that the hematocrit should be kept above 30. Role of intravenous thrombolysis like altiplase and intraarterial thrombolysis in a mechanical thrombectomy, and for restoration of blood flow in acute ischemic stroke has very well established role. And then augmentation of blood flow in the form of maintenance of a volume status, use of mannitol and hypotonic saline to improve the rheological property of the blood, so there is better flow in the there is better microcirculation, and hypertensive therapy. And these things have been found to be very useful in subarachnoid hemorrhage, especially if there is chance of or risk of distal cerebral ischemia in presence of vasospasm or delayed cerebral ischemia. Profound hypothermia has long been used in heart surgery and also in giant aneurysm for providing protection against irreversible brain death when the heart is stopped. And there are various mechanisms of action of this hypothermia, and mostly this is suppression of cerebral metabolism. But there are complications also associated with hypothermia like cardiac depression, coagulopathy, and these complications because of suppression of metabolism and suppression of seizures that limits its usefulness. But studies have shown that even mild to moderate hypothermia can also have protective role without much of the complications of profound hypothermia. And recent trials have shown that mild to moderate hypothermia also is helpful in decreasing ICP after head injury, but unfortunately those studies could not show improvement in the clinical outcome. But 2 trials after post-cardiac arrest in adult patients have shown improvement in outcome with the use of therapeutic hypothermia, and another study in pediatric patients, hypoxic encephalopathy in pediatric patients has shown clinical benefit in the form of improved neurological outcome with the use of therapeutic hypothermia. So, in spite of the variable results, mild and moderate hypothermia is in common use and is used in different setups. But it is very clear that even mild hyperthermia or fever is harmful in presence of acute ischemia, cerebral ischemia, so that should be avoided at any cost or should be aggressively treated. Anesthetic agents affect the pathophysiology of cerebral ischemia in different ways, mostly by decreasing the cerebral metabolic rate, by decreasing the functional neuronal activity, and of course there are other individual actions also. IV barbiturates has been long been used for reducing ICP in head injured patient to provide focal cerebral ischemia, and also during cardiopulmonary bypass, and there are multitude mechanism of action, mostly sodium, potassium and calcium influx, then free radical scavenging action. But again, barbiturates have their own complications like cardiac depression, and that can suppress the cerebral perfusion pressure, and also immune suppressions. Other IV agents like propofol, midazolam, ketamine and lignocaine all have in animal studies have shown that they are neuroprotective and they can reduce infarct size, but unfortunately there is no clinical data. But in spite of this, propofol is still used in different settings, like in the intraoperative period for provision of cerebral protection, mainly for aneurysm surgery, and then to reduce decrease ICP in head injured patients, and also to control seizures in status epilepticus. Volatile anesthetic agents have been shown to be neuroprotective in animal models, and also they reduce infarct site, but and isoflurane and sevoflurane have also this ischemic preconditioning effect. But in contrast to experimental study, the neuroprotective role of these agents have not been shown to be effective in clinical studies like head injury or stroke. Many non-anesthetic agents like magnesium, calcium channel blockers, statins, corticosteroids, hormones and few other agents have been used. They have the potential as a neurocerebral protecting agent, but we need to do more research before these agents can be useful clinically. Brief repeated cycles of peripheral vascular occlusion and deocclusion in dogs prior to induction of myocardial ischemia is known to reduce infarct size, and this remote ischemic preconditioning induces humoral factors that prevents perfusion injury in various organs including the brain. One potential means by which this can be achieved is by application of a standard blood pressure curve and alternative cycles of inflation and 5-minute cycles of inflation and deflation. CNS has this good ability to remodel itself following insult in the form of angiogenesis, neurogenesis, gliogenesis, synaptic plasticity and axonal sprouting, and these processes are stimulated by endogenous growth related factors. So, facilitating the functional and structural recovery of these injured tissue by providing a milieu that enhances the neuroregenerative ability of this has become an important therapeutic target, and in this regard this infusion of mesenchymal stromal cells has been shown to improve structural and functional outcome. So, MSCs basically they secret growth and neurotrophic factors or induce the local cells to do that, like the microglia. So, MSC basically they reprogram the local environment from a detrimental function to a beneficial role, reducing toxic events and providing or promoting a restorative process. So, maintenance of physiologic variables like oxygenation, ventilation and perfusion is the most basic premise of any cerebral protection strategy. So, the most effective weapons in our hand to deal with cerebral protection are maintenance of the cerebral perfusion pressure, control of the intracranial pressure, adequate ventilation and perfusion, maintenance of adequate hemoglobin level, and also control of fever and hyperglycemia. Coming to the conclusion, acute brain injury, whatever its cause, is associated with considerable morbidity and mortality, and ischemia, cerebral ischemia triggers a characteristic pathological cascade that leads to secondary injury and neuronal cell death. So prevention of secondary injury is one of the most important strategy of cerebral protection, and so in our hand we have this control of intracranial pressure, maintenance of the blood pressure, avoidance of any hypotension, adequate oxygenation, ventilation, maintenance of adequate hemoglobin level, control of fever, and control of hyperglycemia, and they are the most important goals or weapons we have for cerebral protection. Thank you.